Thank you. Next, we have Sarah Scamborough, who is a PA for the CNS Psychs, and Dr. Michelle Reed to talk about the task force and give their personal experience regarding the bills and details. Ladies, thank you very much for being here. If you can make yourself comfortable, and whenever you're ready, turn on the mic and it's all yours.
Good afternoon. Thank you so much for having us. I'm Dr. Michelle Reed, and I'm the Chief Medical Officer at CNS Healthcare. We're an outpatient mental health and substance abuse provider with offices in Oakland and Wayne counties. I'm here to speak on behalf of Senate Bill 826 to amend the Michigan Mental Health Code to include physician assistants, nurse practitioners, and clinical nurse specialists as mental health professionals. At CNS Healthcare, we began to hire physician assistants and nurse practitioners around 2014 when we were going to expand our services and added 2 new clinics. The people we serve were overwhelmingly enjoyed these new services provided by the PAs and NPs, and we found them to be valuable members of our treatment team. In 2016, we found out that we were no longer able to have the PAs and nurse practitioners complete clinical certificates to transfer people to the crisis center or hospital for evaluation. And as a result, we ended up experiencing delays in needed care. On one occasion, I was working on a case with Sarah, and she had an individual who she was treating had evaluated and determined that hospitalization was needed, and his condition was worsening. He needed to go to the hospital, and on that particular day I was not in the clinic, and what ended up happening is there was a delay in getting care until I could get there. The individual left the building, came back. It was a whole case scenario there, and we had to redo the clinical certificate, reworking it prior to being transported to the hospital, and it caused a delay in getting care. And this happens several times a month at CNS Healthcare. So in about 2016, I called on several colleagues to address these issues, and we formed a task force. And what we did was review the Michigan Mental Health Code, and at that time, we discovered that physician assistants, nurse practitioners, and clinical nurse specialists were not even described as mental health professionals. So we contacted an Oakland County legislator who sponsored a bill to amend the Mental Health Code to make these changes, and we're pleased that Senator Ruth Johnson, who represents Oakland County, is supporting the new bill. We shared our draft legislation with numerous organizations and revised it based on the feedback. Physician's assistants, nurse practitioners, and clinical nurse specialists provide direct patient care services in community mental health settings all across the state of Michigan. Physician's assistants, nurse practitioners, and clinical nurse specialists collaborate with physicians, psychiatrists, nurses, social workers, peers, and therapists to provide needed evaluation and management, long-acting medication, and Suboxone treatment. Physician assistants, nurses, and clinical nurse specialists manage full caseloads of patients with a variety of mental health and substance use disorders. Physician's assistants, nurse practitioners, and clinical nurse specialists are providing telehealth services during the pandemic to children, adolescents, and adults and older adults with mental and substance use disorders. We ask that physician assistants, nurse practitioners, and clinical nurse specialists be added as mental health professionals in the Michigan Mental Health Code to allow the provision of uninterrupted services to the people they treat. Thank you.
Well, thank you for having us. As Dr. Reed mentioned, I'm Sarah Scamborough. I'm a physician assistant for CNS Healthcare. I also have an MSW, and I'm currently pursuing my PhD in social policy and practice within the School of Social Work at Wayne State. I've been a physician assistant for 10 years, working primarily in community mental health clinics, but I also maintain an outside private practice. I currently serve patients as young as 5-year-olds to geriatric. I provide services that include evaluation and management, psychiatric evaluations, as well as medication-assisted treatment for substance use disorders. I've had the privilege of treating members of our community with diagnoses that include but aren't limited to major depressive disorders, schizophrenia, bipolar, PTSD, and substance use disorders. My purpose every day is to fight for the best interests of our patients. A cursory review of history describes a time where these were people that were socially maligned and stigmatized for merely experiencing mental health symptoms. There is a consistent current of this today, and this is why I champion so persistently for this population. Without the mental health code recognizing people like me as providers, as we are in the public health code, the patients are the ones that will suffer additionally and unnecessarily. Due to the chronicity of their diagnoses and symptoms, I have gotten to know these people over the past decade very intimately. I've been through graduations, births, deaths, and a multitude of significant milestones that I had the pleasure of celebrating with my people. It's always been viewed as a partnership, and this is why I adore working for CMH. There are times, though, when people require services that are beyond our outpatient abilities, which would lead us to hospitalizations. As Dr. Reed had already alluded to, many of our patients experienced clinical disconnect and stress. The one case in particular, which unfortunately is a multitude of many cases that we've had, where I was unable to sign a certification for an imperative hospitalization. This was an additional 3-hour ordeal as I attempted to contact Dr. Reed and manipulate the process while best serving the needs of my patient. This could have easily been truncated and less distressing for the patient if there was parity and representation in the mental health code and recognized me as a provider. The immediate future is a concern with regards to the pandemic and the level of trauma with what is discussed as a looming mental health crisis. Considering adverse childhood experiences, especially concerning our younger populations who have been egregiously rooted from their structure, but also harmed systemically, and secondary to mental health stigma, we need to be better prepared to wholly move to action and care for these patients. Trauma presents as reactions, not memories. Please allow us to continue to treat these patients that we care so deeply for and recognize us as the ably educated and bodies provider that we are. Thank you, Mr. Chairman and Senators, for recognizing the importance of these issues and for the opportunity to speak with you today.
Well, thank you for taking the time out of your schedule to come and testify. Members, any questions? If not, Senator Bison.
Thank you for both coming and testifying today. We very much appreciate what you do for all of those within our communities. Could you tell me a little bit about your relationship with what I presume you have especially if you're writing for medications, you probably have some relationship with a psychiatrist in a mental health setting. Is that correct?
I have a collaborating physician that I work with, but we also work as a multidisciplinary team so that I'm able to communicate with the other physicians that we have on staff.
And I think also to answer your question, yes, at CNS Healthcare, I'm the Chief Medical Officer and I'm responsible. So we have aligned a psychiatrist with all of the physician assistants and nurse practitioners we work with. They have individual work, review cases, perform peer review, and manage and monitor their care, as well as the psychiatrists who are providing care for us. So yes, there's peer review, there are face-to-face meetings, case reviews, and actually sitting in and actually seeing patients with both the physician's assistants and nurse practitioners to continue to monitor their performance. And we do that also for the psychiatrists, absolutely.
And I find that as being a very important part of the relationship. We need to work at this as a team rather than saying, I know everything about everything, because even though we are saying that we can expand scope to a point, I think that it's important to realize that we still have others who have specialized in the care, and after 10 years of experience, I give you a lot of credit, and you know a lot. But even the residents that are coming in typically have 5 years of experience. Is it 4 or 5 years now that they train for psychiatry?
I completed a 4-year residency after I finished medical school, but as you're saying, it's absolutely correct. We are accredited by CARF. We're also a certified community behavioral health clinic, part of the public mental health system with contracts with Oakland and Wayne, and part of the rules and regulation require that all clinical staff are monitored, peer review, and we manage and monitor what they're doing. So yes, everybody.
I appreciate that. Thank you so much for the clarification.
Senator Tice. Is your mic on there, Senator?
There was some, sorry.
Thank you.
There was something you said that I would like clarification on, and you said trauma presents as, and I think you said action, not memory. Can you describe what that means?
When we have our young people, as I yell across to you, when we have our young people in particular, but this goes for anybody, when we are experiencing trauma or we're reflecting back on those events, particularly if we have not had any mental health care, I'm not going to think, oh, this reflects back to when my dad went to prison, when my mom had a substance abuse issue. It's going to be, no, I'm going to punch the teacher. No, I'm going to set fire to something. When we need to act as providers, it's at that moment. No one comes and nicely lays out all the issues, because that would make my job a lot easier. Instead, I have to sift through and get to where are these coming from. And I want people to understand, particularly with the pandemic that's going on and the disconnect and the uncomfortable feeling that we feel. Imagine what that feels like to be a young person. And I do firmly believe that we will see a spike in mental health problems as a result of trauma.
Thank you. Anybody else, any questions? If not, when you started, you said that you've experienced some longer delays. And when you say longer delays, express, if you could, what the time delay is and what that delay has caused in lines of a longer term mental disability or continued prognosis.
Right. In terms of the overall delay in service, it's particularly around securing inpatient care. So 2 to 3 or 4 times a month, about once a week, we'll have an individual who is physically in our clinic and experiencing signs and symptoms that would warrant inpatient care and not outpatient. Ordinarily, that individual must be transported either to a hospital or a crisis center for evaluation prior to hospitalization. And what happens is the court will not accept, we need to complete a petition and an initial clinical certificate just to transport the person to the crisis center, and they will not accept them from a PA. So a physician needs to do that. So on a particular day in question, Sarah was in the clinic, running the clinic. There was no psychiatrist there. She saw this individual. He needed to be hospitalized, and it involved having to get a psychiatrist to either come over there, be on the phone, see the individuals who telepsych, and in this particular instance, the individual left the family member, went out in Novi and was running up and down the street, so it got to be a big harassment with the police and the ambulance to get him back in the building, get him evaluated, and then get him down the road, where initially he was sitting there with his mother, he was ready to go, and then because of the delay in services, he got very anxious, and it ended up being like 3 hours, and what happened was we had to pay the security guard overtime, the front desk staff to overtime, the social worker had to stay over, case manager, so it got to be a big brouhaha at the clinic where had right at the moment that he and the mother and Sarah agreed to hospitalization. If we had been quickly able to call Novi ambulance, police, he would have been out of there, he'd have been at the hospital in 20 minutes from our location. So it causes a delay because the court won't recognize it. As a physician, I delegated the responsibility to Sarah to make a decision about the petition. We'd actually had an opinion from the Michigan Department of Mental Health or Health and Human Services Office of Recipient Rights saying that that was okay to do, that a physician assistant could be delegated anything that a physician said they could do, that they in fact were practicing medicine, but the courts would not recognize that. So unless the psychiatrist or an MD's signature is on the paperwork, the court won't recognize it. And in this case, I didn't even know the individual. He was somebody who was being treated by Sarah. So she had a much more in-depth knowledge of him, his circumstances. We did manage to get him hospitalized, but it causes a delay in care for us in the community mental health setting at CNS Healthcare.
Thank you. One last question, and